Most bacteria we deal with in clinical practice are fast movers. E. coli doubles every 20 minutes. Staph aureus has visible colonies overnight. Mycobacteria operate on a completely different timescale, doubling times of 12 to 24 hours, meaning culture can take weeks to months. That slow growth isn't a weakness. It's a survival strategy that shapes everything: the chronic granulomatous nature of the disease, the difficulty of treatment, and the challenge of diagnosis. Today, we're going to understand why these organisms are built differently and what that means for the chronic diseases they cause. The mycobacterial cell wall is one of the most extraordinary structures in microbiology. Those mycolic acids form a hydrophobic barrier that behaves almost like a second lipid bilayer, extremely impermeable. Water-soluble antibiotics simply cannot cross it. Disinfectants that kill E. coli in seconds may take hours to penetrate mycobacterial cell walls or fail entirely. This is why tuberculosis treatment in humans requires 6 months of multi-drug therapy. It's why Johne's disease is essentially incurable. It's why farm biosecurity for M. bovis infected herds requires specific disinfectant protocols. The wall is the organism's greatest asset and our greatest challenge. Granuloma is a fascinating immunological compromise. The immune system can't kill mycobacteria outright. The organisms survive inside macrophages and block lysosomal degradation, so instead it walls them off. Think of it as building a prison around something you can't execute. This works reasonably well in an immunocompetent animal. The infection is contained, often for years or a lifetime. But two things disrupt this equilibrium. First, immunosuppression. Corticosteroids, concurrent viral infection, malnutrition, age can weaken the granuloma wall and allow reactivation. Second, the granuloma itself is a problem therapeutically. Drugs cannot easily penetrate the fibrous and lipid-rich barrier to reach the organisms inside. This is why tuberculosis treatment is so prolonged and why drugs need to be lipid soluble to have any hope of working. Tuberculosis is a disease where the diagnostic test is as interesting as the pathogen itself. The tuberculin skin test exploits the very immune response the animal mounts against the organism. When a cow is infected with M. bovis, its T lymphocytes are sensitized. Inject purified protein derivative from M. bovis into the skin, and those sensitized T cells mount a delayed type hypersensitivity reaction at the site. Swelling, induration, measurable at 72 hours. No antibody test, no culture. You're reading the cellular immune response. The comparative cervical tuberculin test uses both M. bovis and M. avium PPD. A larger reaction to M. bovis PPD than M. avium PPD constitutes a positive. This distinction matters because environmental Mycobacteria can cause nonspecific sensitization. Elegant diagnostic immunology. Johne's disease operates on a uniquely challenging timescale. The animal is infected as a neonate, often within the first few days of life in a contaminated environment, but clinical signs don't appear for 2 to 5 years. By the time the cow is scouring and losing weight, the pathology in the intestinal wall is severe and irreversible. MAP has been slowly destroying the mucosal architecture of the small intestine over years, creating a protein-losing enteropathy so severe that plasma proteins leak faster than the liver can synthesize them. The resulting hypoproteinemia drops the oncotic pressure and fluid shifts to the interstitium. You see the classic bottle jaw and ventral edema. The animal is eating normally because appetite is preserved. It just can't absorb what it eats. No drug can reverse established granulomatous ileitis. Test and cull, combined with rigorous neonatal management to prevent fecal-oral transmission, is the only effective strategy. Dermatophilus congolensis deserves a special mention because it's extremely common in large animal practice and often underrecognized or misidentified as a fungal infection. Rain rot, matted crested lesions along the dorsum of horses and cattle, is caused by this actinomycete, not a dermatophyte. The organism produces motile zoospores that spread across wet skin, especially when damaged by prolonged rain exposure, ectoparasites, or trauma. The characteristic lesion is the paintbrush crust that lifts off to reveal moist hemorrhagic skin beneath. Treatment is actually straightforward. Penicillin or oxytetracycline combined with removing the animal from wet conditions. But the disease recurs if the management environment isn't addressed. Nocardia, by contrast, is a genuine therapeutic challenge, often requiring prolonged combinations of trimethoprim sulfa with amoxicillin or imipenem, especially in immunocompromised cats or dogs. Unifying theme for this talk is time. These organisms operate slowly, and that slowness shapes everything. The years-long incubation of Johne's disease, the weeks needed for culture results, the months of therapy required for tuberculosis, the chronic progressive nature of all granulomatous disease. It also shapes prevention. By the time clinical signs appear, the infection has been established for years, and control measures are reactive. The most effective intervention point in Johne's disease and bovine TB is years before clinical disease through testing, culling, and neonatal management. These are herd level, program level problems that require a long view. Understanding the biology tells you why short-term thinking fails. Read the case, think about it, we'll then work through it together. This presentation is the clinical textbook for Johne's disease, MAP infection, the combination of chronic non-bloody diarrhea, weight loss, preserved appetite, no fever, and hypoproteinemia in an adult cow is highly characteristic. The edema requires a pathophysiological explanation. MAP-induced granulomatous ileitis progressively destroys the villi of the small intestine. The absorptive surface area is dramatically reduced and the inflamed mucosa becomes leaky, allowing plasma proteins, especially albumin, to pour into the intestinal lumen faster than the liver can synthesize new albumin. The serum albumin falls below the threshold needed to maintain oncotic pressure. When oncotic pressure drops, the Starling forces that normally keep fluid in the vasculature are overwhelmed, and fluid redistributes to the interstitium. Gravity-dependent and lax subcutaneous areas first, which in a standing cow means the intermandibular space, bottle jaw. The diagnosis is confirmed by fecal PCR or ELISA serology, though sensitivity is higher in clinical animals than in subclinical ones. Read the case question, think about it, and then we'll work through it together. This gets to the heart of which arm of the immune response M. bovis infection primarily stimulates. Mycobacterial infections are predominantly controlled by cell-mediated immunity, specifically by sensitized T lymphocytes rather than by antibody. In the early and latent phases of infection, circulating antibody titers may be undetectable or unreliable, which makes antibody-based tests insensitive for detecting infection. The tuberculin skin test detects sensitized T cells directly. Intradermal injection of purified mycobacterial proteins triggers those memory T cells to recruit and activate macrophages at the injection site, producing the characteristic induration and swelling at 72 hours. A positive test tells you the animal's been sensitized. Its immune system has encountered mycobacterial antigens before. and mounted a response. It does not confirm active disease, does not tell you about bacterial load, and can occasionally be positive due to infection with environmental mycobacteria. That's why the comparative test comparing responses to M. bovis and M. avium PPD improves specificity. Read the question, think about it, we'll then work through it together. This is rain rot, Dermatophilus congolensis, and it's being treated for the wrong organism. The owner has assumed a fungal cause, which is a common mistake given the superficial similarity of crusty skin lesions. But Dermatophilus is a bacterium, an actinomycete, not a fungus, and antifungal therapy has no activity against it. The clue is the environmental context. Prolonged wet conditions are the key predisposing factor, and the classic lesion of paintbrush-like crusts along the dorsal midline that lift off in tufts to reveal moist, bleeding skin beneath. Correct treatment is penicillin or oxytetracycline, either injectable or topical, combined with gentle removal of the crust after soaking and critically moving the animals out of wet conditions. If the horses remain in a muddy, wet paddock, the zoospores will continue to reinfect the skin regardless of antibiotic treatment. Management and antibiotic treatment must go hand in hand.